Live. Hi everyone, thank you for joining our second Cancer Research UK and Science on Google Plus Hangout on Air. This time we're talking about childhood cancer, and joining me is my co-host Dr. Kat Arney. Hi Kat.
Hello, hi.
And just a warning to everyone watching us, we've been having a massive amount of technical issues, so fingers crossed everything goes well, but if it doesn't, please be kind to us. Thank you. So, Pam and Richard, could the two of you just introduce yourself, briefly tell us who you are, what you work on, before we go into the questions?
Okay, shall I start? I'm Pam Kearns. I'm a paediatric oncologist based at the Birmingham Children's Hospital, and I'm also the director of the Cancer Research UK Clinical Trials Unit at the University of Birmingham. And my interest is in developing new treatments for children with cancer through clinical trials.
My name's Richard Gilbertson. I'm based at Cambridge University, where I'm the director of the Cancer Centre and the chair of oncology here. I just started 5 weeks ago, and for 15 years was in the States, and I was the scientific director at St. Jude Children's Research Hospital, which is a large children's cancer hospital in the US.
Awesome. So let's kick things off with a question. Maybe Richard, you can start answering this, and Pam, if you have anything to add, you can tell us. What's the difference between children's or teens cancers and adult cancers? Is it two different types of cancer, and do we need a different approach to researching and treating them?
Yeah, that's a great question. So the simple answer is they're very different. And so on one level, the general public would recognize that children and adults get very different kinds of cancer. So whereas adults tend to get breast, stomach, pancreatic, colon cancer, those sorts of cancers don't occur or are exceptionally rare in children. The kind of cancers that we get in children, commonly of the blood, of the brain, and other tissues, and we think that they relate largely to things that go wrong during development, particularly how the cells would normally form organs. That goes wrong. And so a lot of the cancers in children look a bit like developing tissues that have just overgrown. But they are cancers just in the way that adults can have cancer, and they need serious treatment. The biology is very different between adult and pediatric cancers, and we think the underlying causes for those diseases are probably different as well. And we can talk more about that in detail if people would like to. I think in terms of treating, obviously they're extremely different. The younger sort of age group, those sort of children now are treated in children's hospitals as part of specialized cancer units, and that's incredibly important to facilitate the research and the care of the broader family as well as the child with cancer. The group that Pam will be able to talk more about as a practicing oncologist is the young adults and teens group, that group that sort of are in the middle between adulthood and childhood. And they're a very special group that we have to look after particularly carefully with cancer, not just their actual needs for their treatment in terms of the disease, but also their psychosocial needs as they're going through major changes as they're growing up into adulthood. But I'll let Pam comment on it as well.
I think we're going to come to that sort of area a little bit later, but I thought it'd be quite nice, Pam, if you could explain a bit about how far have we come in terms of treating childhood cancers, in terms of the progress we've made so far, and is this the same across all types of cancer that affect children and young adults?
No, again, another great question. The often quoted statistic about childhood cancers is that we can cure 80% of children with cancer, and we describe cure rates as the number of children who are still alive following diagnosis at 5 years. It's a statistic that's used in clinical research, and that's a fantastic statistic. If you think that when I was a child, which is a while ago, cancer was an incurable disease, basically, and over the last few decades, we've made massive strides to get to this average number of 8 out of 10 children being cured. But what that number hides is two really important facts. One is that if you do the calculation, that still means that 300 children a year in this country don't survive cancer, and that's still the commonest cause of death and disease with children. And the second thing is that it's a spectrum. As Richard said, it's not just cancer, isn't just one disease in children. It's a lot of different diseases, more common at different age groups and in different parts of the body. And for some of those diseases, a type of leukemia called acute lymphoblastic leukemia, for example, we have very, very good treatment and very good survival cure rates, well over 90%. But there are other diseases, and importantly, a large group of brain tumours and the bone tumours, the Ewing sarcoma and osteosarcoma, where we haven't made the progress we really need to. And that they are diseases that we are still struggling to develop new treatments. We know the drugs we've got at the moment aren't giving us the cure rates that we need. And then overall, even in the group of patients that we do extremely well, that we can cure, children have to live a long time with the side effects of the treatment that we give them. And so we need to be much better at making the treatments we give them now not have an impact on them in the future. The side effects, for example, the effects on their fertility, the effects on particular organs like the heart and the kidneys, can carry on for many years into the future. So we need to make the drugs better and easier and kinder on the body without losing the effect on the cancer. But we also need to develop new treatments for those that just aren't responding to the drugs we've got at the moment.
And that brings us very well into the next question that I wanted to ask you both. What are the big research challenges at the moment in developing these kind of treatments? Because as you just said, yes, the side effects can be extremely debilitating for these patients at such a young age.
Yeah, so I think would you like me to answer that, or?
Yeah.
So I think in terms of the biology, and actually paediatric cancer is quite a success story. I mean, we have made some considerable inroads in understanding the biology of children's brain tumours, of children's leukemia, and even in some of the solid tumours that Pam described, which are very tough to treat. But there are some very significant challenges in taking those disease, that understanding of disease, into clinic and making an impact on patients. Some of that's the rarity of children's cancer. Although, as Pam pointed out, it's the commonest cause of disease-related death in children, it's still a relatively uncommon condition, which means the populations of patients that are available to treat are quite small. And as we understand the biology better, I think we're poised more than ever to understand the biology of cancer better in children. We take what was at once regarded as a sort of brain tumour or a solid tumour or a leukemia and divide it into smaller subgroups that we know have particular mutations that are driving the disease. That's great because we understand the disease better, but what it means is that we have an even smaller pool of patients. That's fine, but the challenge for us now means that rather than doing sort of local studies or even national studies, we have to start thinking about doing international studies. How do we collaborate better with the US, with the wider European community to make sure that we do these clinical trials for patients? So there's that aspect in terms of the challenge of biology. But actually, I think paediatric cancer is a success story in terms of understanding cancer biology. And I know we're going to talk a little bit later that we can actually learn a lot about the insights of adult cancer by studying paediatric cancer as well.
And Pam, maybe could you talk a little bit about the challenges of the research to try and find kinder treatments? How do we go about trying to do that and try and reduce the long-term side effects that you talked about?
Sure. I mean, any change in treatment has to be based on evidence, and that's why we do clinical trials. And a clinical trial is where we ask patients to participate in what is effectively an experiment where we're trying to introduce new treatments. And there's broadly two types of trials we do. There's trials where we compare the current gold standard and we try to introduce a new treatment, and the question we're asking, is this new treatment better or kinder? And then there's a whole class of other trials where we're trying to bring in really novel, innovative treatment, and that's where we're actually saying, is this drug safe and does it work? And they're much smaller trials. To bring in to examine kinder treatments, we need to do these randomized trials where we're comparing the new treatment against the current gold standard. And the absolute crucial point is that if it's kinder, it can't be less effective. So the trial that you run has to answer the question, is it as good? Is this new treatment going to be at least as good as the old treatment? And ultimately, is it kinder? And these trials are quite difficult because you need quite large numbers to show that difference. And as Richard commented, childhood cancer is rare. We have 1,500 new cases overall of childhood cancers in this country a year, And if you try to run a clinical trial to answer these questions, you're usually looking at comparing hundreds of patients in each arm. So the only way we can do these sorts of studies is to work internationally, and that has complexities, just from the logistics of running trials across national borders, and the financial limitations that go along with it. So if you sit down with a piece of paper and work out how to do it, it's easy. When you try to deliver it in practice, there's an enormous number of hurdles that we have to deal with.
But I was going to ask, though, what's the current picture with UK cancer trials in children and teens? Because we've done really, really well, haven't we? We've had things like the Children's Cancer and Leukaemia Group and now the Children's Cancer Trials team. Roughly how many trials have we got running here in the UK and with your international collaborators?
So thank you for mentioning the Children's Cancer Trials team. So this is a team that sits within our trials unit. And it's a unique team. It runs the national portfolio for all childhood cancer trials that are run by academics. I'm not talking about clinical trials run by the pharmaceutical industry. And we have an oversight of the whole portfolio of trials. So the absolute number, we have 14 trials open with patients going into them at the moment, with another, I think it's 10 to 12 trials where we're following up in the long term. So no longer getting new patients, but we're collecting the data going on. And then we have currently 11 trials that are in the setup phase. So we've got the scientific approval for them, we've got the funding to run them, and we're going through all the regulatory process to get the trials up and running. And then behind that, there is at least 6 grant applications being prepared and another dozen trials that we're developing and designing. So huge. And to put that into a sort of more understandable perspective, today we have an open trial. When a child is diagnosed, there's an open trial for somewhere between 65 and 70% of children newly diagnosed with cancer. So when they're in their treatment centre, the doctor would say, would you like to participate in this clinical trial? And extraordinarily, and it is a testament to the altruism of children and families, we have a hugely high recruitment rate. Just somewhere around about 80% will agree to go into the trials.
That's amazing.
Huge number. And you put that in the context of adult cancers, where it's considerably less than 1 in 5 would go into a clinical trial. We're at the other end of the spectrum. But what I'm very excited about is our portfolio of trials also includes a set of trials that are for patients not at diagnosis, but who have failed treatment, where the disease has come back, and that currently there's no known curative treatment, and we're trying to develop new innovative treatments. And we have a portfolio of these new trials for children with diseases that are difficult to treat, where we're going to develop the next generation of treatments. And that's something that, as a unit, I think we've made great progress over the last 5 years.
So, Richard, you mentioned something about how the UK fits in internationally and how now there's the increasing need to do more international collaborations. Where does the UK fit in, and what are the logistics of doing an international clinical trial for childhood cancers?
Yeah, so I think the UK has always had a leadership role in the international scene of paediatric cancer, and that's not changed. Whether you go back through the history of leukemia studies, many of which were driven by the MRC in the UK, and that's always been the case. And as someone who spent the last 15 years in the US, there is a real respect for the science and the clinicians within the UK. I think increasingly also there's a leadership role on the national scale and international scale. So as Pam's alluded to and I described earlier, because of the rarity of paediatric cancer, we're going to have to look beyond our borders. Every country is going to have to do that. In the US, we realized that with the rarer subpopulations of patients with cancer, we simply can't complete a clinical trial in a time that's acceptable just by operating within a country. That presents a huge challenge. It is an enormous challenge, as Pam's already said, to work across borders with the medical regulatory bodies, etc. But we're going to do it. That's the bottom line. There's a huge amount of will to do it. It has to be done to save the lives of children, and there's no question that that will happen. I think the UK is particularly well positioned because of the expertise in its universities. I mean, the UK, one of the reasons I came back here is the UK has some of the best seats of learning, quite honestly, in the world. Some of the best scientists in the world. I spent last Friday with a bunch of engineers, and all they do is tune light to pick up different proteins in cells, and they were all around the table thinking about childhood cancer. That's an amazing opportunity that you just don't see anywhere else in the world. So I think the UK has this sort of innovative aspect and an imaginative aspect to science that will really bring forward ideas which will really have an impact on the lives of children in the future.
And you've just come from St Jude's in the US. Are you going to be maintaining those links? It would be nice to think about the sort of the research collaboration. What can we learn from the colleagues you've left behind in the US?
Absolutely. So actually, I have 2 collaborative grants with the US, particularly for with St Jude and other colleagues in the US, particularly to develop new drugs for pediatric brain tumours. I think in terms of teaching the adult community something, these aren't just taking drugs that have been used for other purposes. Actually, one of these studies are completely new compounds, new chemicals that have never been used as drugs before, that will now be used to treat a particularly rare kind of tumor called chorioplexus carcinoma, which occurs in babies. It's a brain tumor which is a very difficult disease to treat. So we have new opportunities to develop brand new drugs. They themselves actually might be useful in adult cancer. And so pediatric cancer has a lot to teach adult cancer, both about the biology and the way we treat it as well.
And sort of moving on a little bit from children, very young children with cancer, Pam, perhaps you could tell us a bit more about some of the particular challenges of working with teens and young adults with cancer, some of their particular needs.
So that's an enormous subject. So the particular problems that teenagers face, so the types of cancers they get often go across quite a broad age spectrum. And so they're either sitting at the older end of a paediatric type of cancer, or they're at the younger end of an adult cancer. And then they have some cancers for which they are the biggest age group for developing them. So in particular, the bone tumours, so Ewing sarcoma and osteosarcoma. And they're small numbers overall. The trials that we do at the moment, there's been a traditional split for no genuinely logical reason, to be honest, that trials finish at 16 or 18 because that's a childhood trial, and adult trials go down to age 18 because then you're an adult, and never a crossover in between. And that has changed. That is changing, and we have to keep pushing that change. So, for example, we run trials now for Ewing sarcoma where they are international, and just to say international isn't just transatlantic. We have a massive European network, and we work very closely with our European colleagues. Even with the language barrier, we are able to work incredibly well running these trials. So we run a Ewing sarcoma trial where the age goes up to the full spectrum of when Ewing sarcoma will present. So young children, teenagers, into young adult and older adulthood. And that's how we look at all trials now. So we can do that. We can write a trial, we'll do the research project, we will develop the new treatments across the age groups. But then you get the practical delivery, and Richard alluded to a little bit to this before. At what age does a child no longer sit in a children's hospital and need to go to an adult hospital? And the Teenage Cancer Trust have done an enormous amount of good work in developing teenage cancer units. But they vary in models, and I have to say, talking to my European colleagues, and I'd be interested to know what happens in the US, but we have advanced this more than any other country that I know, that where we have these units embedded either at the top end of a children's hospital or in an adult hospital, or in some trusts where they take both age groups. But it still requires the expert staffing. It's not good enough to just have a paediatric team going into a teenage unit and then looking after a 24-year-old, or vice versa, an adult team coming in and looking after 16-year-olds. It's a whole new specialty to address the needs of what it's like to be a teenager diagnosed with cancer at a time which is difficult for the average teenager to cope with all the things that change around you as a teenager, and you're growing independence, and then we give you a big disease and a life-threatening diagnosis, and you've got to deal with that on top of it. So all the psychosocial needs, the development needs, the educational needs need to be tailored to that age group. And we need to do that alongside making sure they have access to the treatments, and there's no artificial age at which we stop allowing them to go into a trial. I work with a number of patient and parent groups. There's some particular patients that come to, or parents that talk to me about their children who didn't survive cancer. And they were frustrated because trials were open in adult units for the disease their child had, but because their child was 17 and a half and the age of going into the trial was 18, they weren't allowed to get access to those drugs. And we have to stop that happening in the future, because there's no difference between a 17-and-a-half-year-old and an 18-and-a-half-year-old pharmacologically, so there's no reason why that drug can't be given to them. And so we're doing a lot of work with all the relevant stakeholders, the parents, the regulators, the pharmaceutical industry, to say, let's stop this happening in the future. Let's make sure a new drug, if it's relevant to a disease in young people, let's make sure it's accessible to young people as well.
Absolutely. I mean, bureaucracy like that shouldn't stand in the way of, saving lives like that. That's such a horrible story. And as if puberty wasn't bad enough already. So one of the things that we asked early on in the Hangout was what are the differences between childhood cancers and adult cancers? So and Richard, you said they're very different. What can we learn from those differences between kids' cancers, teenage cancers, and adult cancers? Can we apply those learnings across the different cancers?
Yeah, you can. I mean, so basically, if we think about cancer, although cancer arises in very different contexts or tissue types between adults and children, so as I've mentioned, whereas adults get breast, pancreatic, stomach cancer, kiddies get leukemia, brain tumours, neuroblastoma, which is a sort of tumour of the peripheral nerves in kiddies. We see that happening. But the things that go wrong in cells that drive cancer, the processes that control cell growth, cell death, how a cell grows up and does the job it's supposed to, those things quite commonly go wrong in both adult and children's cancer. So if we understand the biology of how a cell should divide, and that might be an insight that we get from a child's cancer, it can and has been applied to adults. There is one very specific area which is particularly exciting, where we are learning from adults for children, and I'll give another one for vice versa, and that is in repurposing drugs. So technological advances often drive new changes in the way we treat cancer. One particular technological advance that's happened in the most recent years is the ability to do very high throughput drug screens. So that's take cell populations, so cells that come from a child's cancer, and literally test them against millions of compounds. We've done that at St. Jude, that's happening in other places in the UK. And we can include in that all of the drugs that we use to treat an adult cancer, about 300 cancer drugs that are currently in the market. Now, it would be completely impossible to do clinical trials because of the rarity of childhood cancer with all of those drugs in every single childhood cancer. But we can test whether childhood cancers are sensitive to chemotherapies that are currently used in adults. My own lab did this recently to take a very common drug used in breast cancer, and is now what we call repurposed it. We're now using it to treat a childhood brain tumor. We would never have selected that drug before. In terms of biology, we can take very real insights into the basic aspects of developing tissues, how that goes wrong to make a childhood cancer, and that will often unpick and identify biological processes that are going wrong to control tissues that actually also occur in adulthood. Now, adults their cancers tend to have many more genetic alterations than we see in children's cancers, and so often there's a lot more noise going on in an adult cancer. So if you can see a much clearer, sharper picture of what's going wrong in childhood cancer, you can then tune in and look at that in adult cancers, and there are examples of where that's been done.
But if I could just come back on that as well, Richard, I think that kind of work is very, very informative, and as you say, it helps us have a better idea of selecting which drug should we be taking into the clinic. But there is a practical problem which we're facing at the moment, and that is being able to access the drugs that are being developed by industry mostly into paediatric trials. And the problem is the rarity of childhood cancer. So if a company is developing a drug for a disease like breast cancer or lung cancer, in fact most adult cancers, it has a market. If it proves it works, it has a market, and it will get the financial benefit from all the investment, and it is a huge investment into developing a drug. Childhood cancer, we've been talking about the numbers, how small they are, and so stacking up, it's not a profitable way to do things. in Europe and in the US, there are rules now, regulations that have been pulled into place, and in Europe it's called the Paediatric regulation, to mandate drug companies to do studies in children, so that we don't have the situation of drugs that have been developed in the adult market and then we have to just try them out as best we can, that they are formally part of the development plan. But at the moment, it's not translating into getting lots of drugs into the clinic for children, because there are still ways of getting around it. Because if you have a drug that's been developed for lung cancer and you want to license it, you can say lung cancer doesn't happen in children, and under the regulations you then don't need to do the children's trials. But Richard very, very clearly stated there are the mechanisms that cause the cancer, the lung cancer, could easily be applicable in a paediatric cancer, and we have some good examples of this, and where the target the drug has been developed to hit, for lung cancer, is also relevant to a paediatric cancer. So we're working very hard with all the people involved, again the regulators and industry, to say, can we find a way that will mean that you will allow us access to drugs on the basis of its mechanism and not the disease it was developed. And if we can get that change in attitude and a change in the pathway, then we'll have much more intelligent way of developing new drugs for children. And I can see progress already in that direction, and I would expect over the next 5 years that we're going to be in a position of being able to look at the massive portfolio of drugs that are coming out of industry at the moment and say, yes, now we can have access to those and do much cleverer interactive trials that are targeted for patients, not just diseases.
I just wanted to mention as well that, I mean, cancer treatment isn't just all about drugs, is it? We probably don't have time to go into all the ins and outs of different types of radiotherapy, but also we are running trials of things like more precise radiotherapy here in the UK, aren't we, as well?
Absolutely, and I think it's the full spectrum, including surgery as well. We mustn't forget surgery, which has a major role to play in paediatric cancer as well. And so, you know, what's exciting also among the paediatric community, and I think Pam alluded to this very well, is that the paediatric community, partly because of the rarity diseases, forced us to work together. So we have a very long history of close interactions between the different disciplines: surgeons, radiotherapists, oncologists, nurses, and pathologists, forming very tight groups of people who work closely together every day, not just to deliver care, but also to do the research which will deliver new treatments for the future across that spectrum of disciplines.
And just really to wrap up, because I can't believe how fast the time has gone, we're nearly out, but maybe each one of you, if you could just tell us a very brief story about a patient that you've met that has had an impact on you, perhaps maybe sums up why you think it's so important to carry on with this research, or perhaps even the hope that you have for the future. Richard, if you'd like to go first.
Okay, I remember lots of patients, but the one patient I remember the most was the first child I ever met with cancer. Before I'd even thought about doing childhood cancer as a career. And she was in a bed in the hospital I was working at as a medical student. And we asked what was happening, and the consultant, who was a fantastic consultant, said, we've done everything we can for her, and there's nothing else we can do, we just have to let her die in peace. And that really haunted me for a long time. And I read a book later on by a guy called Don Pinkel, who's a very famous oncologist in the States. And having had that experience with that patient, I then read that book, and he said he'd had the same experience, but he said that children don't die in peace with cancer, and it's not acceptable to let them die in peace. And that's really what one of the things that really spurred me on to a career in childhood cancer research.
Fantastic story. Pam, have you got a story that you'd like to tell us that sort of sums things up for you?
I was like Richard, you spend your whole career meeting lots of amazing families, and so it's really hard to pick out one, because they all have an impact on you in one way or another, whether their child has survived or in the situations when they don't survive, and you carry that along with you in your career. But there are just a couple of things I just wanted to say on that. One, what is just a bit like Richard, not my first patient with cancer, but it was the last patient I saw just prior to going into the laboratory to start some laboratory-based research. When I started sort of a career in research, and I was in the clinic, and I was talking to the family and saying, you know, I won't be seeing you in clinic next week because I'm going off to the laboratory to become a researcher. And we chatted a little bit about what I was going to do. and this mum took my hands and looked me straight in the eye and said, "And will you be finding a cure for my child?" And it was so heartfelt, and it made me realise that every piece of work we do as researchers, we have to remember that it isn't just for academic interest, it is actually to make a difference to those patients in the clinic. And just if we have time, just one other very short story, it's very, very recent. And I've heard this several times, but it brought it home to me in a very passionate plea I had from a father recently, whose child has a tumour that we have no known cure now for her. And he said to me that we were talking about new drug development trials, and he said he could not believe in this day and age, with all the knowledge that we have, that globally we do not have a cure for his child. And I thought, you know, that is just not acceptable, and we really do need all the work that we're doing. We really do need to be in a position, and I don't know how long it's going to take, but we never have to have that conversation of there's nothing else we can do. As Richard said, that it's just not good enough, and we need to keep working at that.
Absolutely. Thanks very much.
I think that's something that comes across very clearly in the words that the two of you have said, that this is simply not acceptable, and you're not just going to, you know, put up with it. It is what it is. That's not your attitude, and that's really inspiring, and I hope that the people watching find it similarly inspiring. I find it inspiring to hear from the two of you like that. So thank you so much for your time, and thank you, Kat, for dealing with the broadband issue. We got there in the end, and thanks everyone for watching, and I hope you enjoyed this. With regards to the next Hangout we're doing, the topic's open for discussion, so if anyone has any cool ideas of any topic you'd like to hear about, let us know. We have access through Cancer Research UK to some of the best researchers in the UK, so we can make that happen if you have a particular topic you'd like to learn about. And that will be in 2 months' time. So thank you for joining us, and goodbye.
Thank you. Bye.
Bye.
Goodbye.